patient with diabetic nephropathy. Welcome.
Thank you very much. It's delightful to be here. I think I'm the only pathologist in the room. Hands up if you're a pathologist. Yes, I was right. Excellent. I've had a lovely week in Kenya, and amongst my pictures will be some of the friends that I met in the Masai Mara over a couple of days earlier this week, starting with some wildebeest. What is a pathologist doing here, talking to nephrologists and trying to tell them when to biopsy their patients? In my experience, nephrologists never listen to me when I tell them when to biopsy their patients. So hopefully I'll be able to provide some useful information that will assist you in this decision. I'm going to change the question slightly to why to biopsy a patient with diabetes. And as far as I can see, there are three possible indications. First of all, doesn't work very well, the spotter, does it? No. To confirm a clinical suspicion of diabetic nephropathy, to classify or stage the diabetic nephropathy for prognostic reasons, and thirdly, to exclude other renal diseases in your diabetic patients who present with atypical clinical syndromes. So we're going to start with a show of hands. Those are your three options. Who's going to go for option one? Hands up. Option two? Option three? Okay, well, that's the end of the talk then. We're all agreed. Excellent. I think I come to the same conclusion, but you will find out in 20 minutes. So I'm going to start off running through what the pathologist sees in the diabetic biopsy and what it means for the patient and how the patient gets there. Diabetic nephropathy is really a summation of the microvascular disease which affects the arterioles and the glomeruli in the kidney, but also together with the macrovascular disease, so atherosclerosis, renal artery stenosis, and hypertension. And together, the final common pathway is progressive atrophy and fibrosis and end-stage kidney disease. And when you get down to this stage, at the bottom of advanced atrophy and fibrosis, often the changes are rather non-specific. The earliest changes that your diabetic patients will suffer in their kidneys are clinically silent, and that's the stage of hypertrophy. I'm very familiar with diabetic kidneys in my autopsy work, and they are big. They're usually about 50% bigger than the average person's kidneys. And this also applies to the glomeruli. That is a huge glomerulus. But this doesn't give rise to symptoms. The kidneys, as the nephropathy progresses, tend to shrink. But even at end stage, the whole kidneys are of pretty much normal size. The first real detectable feature of a diabetic glomerulopathy is seen on electron microscopy, and that is thickening of the glomerular basement membrane. So I've got two pictures here, one normal basement membrane on the left, and at the same power on the right, a diabetic glomerular basement membrane, marked thickening from around about 300 nanometers to easily over a micron in thickness. And this is clinically significant and does correlate with progression. But most of you won't have access to electron microscopy, and you actually don't need it in diabetes because by the time your patient presents with clinical manifestations, that they will have light microscopical changes. So from a normal glomerulus here seen on an H&E silver, the first abnormality is an increase in mesangial matrix, often with some mesangial hypercellularity, and that will progress over several years to finally fully blown diabetic nephropathy with nodular glomerulosclerosis. The nodular sclerosis is seen against a background of mesangiolisis, breakdown in the mesangial matrix, unfolding of the capillary loops and capillary microaneurysms. There are also insudative lesions reflecting the endothelial injury. So these are accumulations of plasma protein-like material, which seen on EM look rather sort of fuzzy and granular, between the endothelium and its basement membrane. At the same time, there is evolving arteriolar hyalinosis, seen here on the H&E and PAS on the right. So this glassy thickening of the arteriolar walls. In general, the arteriolar changes parallel the glomerular changes and do correlate with prognosis. However, I see many cases of an advanced diabetic glomerulopathy with little or no arteriolar hyalinosis. And this can cause problems in the differential diagnosis for the pathologist, because the main differential diagnosis for diabetic nephropathy for the pathologist is light chain deposition disease. And this is a non-diabetic patient with light chain deposition disease, showing very beautiful nodular glomerulosclerosis, silver on the right to show you, yes, the nodules are made of collagen, not just light chain. And I regularly get biopsies from my nephrologists with the history, diabetic patient with deteriorating renal function, nephrotic proteinuria, and a paraprotein. Is it diabetes or is it light chain deposition disease? Based on light microscopy, that distinction will be very, very difficult for me to make. So your pathologists need to have access to really good immunofluorescence or electron microscopy. So that's what light chain deposition disease would look like. In this case, it was a kappa deposits in the glomeruli and tubular basement membranes. And the EM looks very different from diabetes. So when you send the biopsy to your pathologist with the question, is it diabetes or light chain deposition disease, have a thought for them. Send them material sufficient for them to do immunofluorescence, because they can't demonstrate light chain restriction on peroxidase, on paraffin sections very easily. And if they say, sorry, I can't tell the difference because I can't do electron microscopy, that's the truth. There is another cause of nodular glomerulosclerosis, and that we used to call idiopathic nodular glomerulosclerosis, otherwise known as diabetic nephropathy, no diabetes. So pathologically, this is identical to diabetic nephropathy, but the patient doesn't meet the criteria for diabetes mellitus. But most are obese with the metabolic syndrome, and this, in a way, is the nephropathy getting ahead of the diabetes. Okay, that's the end of a brief run-through of the pathology of diabetes. Now I'm going to go to item 2. Nobody put up their hands for wanting to do a biopsy to classify the diabetic nephropathy for prognostic reasons. And I'm glad about that, because I agree with you. But I will quickly run through the classification. And this, nearly 10 years ago, an international working group of pathologists put together this classification of diabetic nephropathy based on the histology. Class 1, virtually normal LM, with GBM thickening on electron microscopy. Class 2, diffuse mesangial expansion divided into mild and severe. Class 3, I'm not sure what happened to moderate. There's usually a moderate between mild and severe, but don't worry about that. Class 3 is the stage of nodular glomerulosclerosis, the Kimmel-Steele-Wilson lesions, and Class 4, advanced chronic damage with more than 50% global glomerulosclerosis. Now, those of you who are still listening to me and not thinking about your lunch will realize this is not a classification of diabetic nephropathy. This is a classification of diabetic glomerulopathy. There is no mention of blood vessels or tubules or interstitium in this classification. And the other thing to note about this classification is that the classes and the subdivisions between them and within the classes are entirely arbitrary. Some pathologists like nice round numbers, like 50% and 25%, irrespective of whether there is any evidence for these numbers. So always be wary of a classification that comes up with these arbitrary divisions. What's the evidence for the use of this classification? Well, there was an early study that demonstrated that the various classes had very different outcomes in terms of renal survival, and that's pretty impressive. And in multivariate analysis, both the glomerular lesions and the extent of interstitial fibrosis and tubular atrophy were independent risk factors for progressive renal disease in these patients. But many other studies have demonstrated that it's not the glomerular lesions that are most important in predicting outcome in the patients, it's the tubulointerstitial lesions. And your pathologist should be giving a percentage interstitial fibrosis and tubular atrophy to you for all of your renal biopsies, including in diabetes. So here we can see a study that demonstrated that the extent of IFTA were associated with renal survival, but not the glomerular class. And in the second study, again, the extent of IFNA this time correlated with the rate of decline of renal function, but not the glomerular class. A very recent study published this year demonstrated an association between glomerular class and outcome in univariate analysis, but it completely dropped out of significance in multivariate analysis. And you were really left with baseline GFR and proteinuria and extent of IFTA as predictors of outcome in multivariate analysis. So I don't use the classification of diabetic nephropathy, but I do give all of the numbers to indicate level of chronicity, in particular the percentage interstitial fibrosis and tubular atrophy. Now, a very recently published publication from a Japanese group has included the vascular and the tubular interstitial changes together with the glomerular changes into a classification scheme. And when you look at the survival plots for their 4 grades, based on a summation of all of the changes in the biopsy seen on the right of the slide, you can see a very nice separation. But this is a really complicated classification for your pathologists to apply, and if you look if you can read the numbers on the right, most of the weighting is based on IFTA in the middle. So I would advise pathologists to include much of the information, but focus on the interstitial and tubular changes. Right, finally, item 3, the one we all voted for. Excluding non-diabetic kidney disease in our patients with diabetes. I'll just run through a few studies that demonstrate the frequency of non-diabetic disease in our diabetic patients, and then give you some examples of the potential confusions that this can cause. So in general, when you biopsy a diabetic patient, one third will have diabetic nephropathy, 1/3 will have something else going on, and 1/3 will have both. But did you know that when you're sending your biopsies off to your pathologists and they're looking at the biopsies, they're judging your clinical acumen based on the frequency that you are biopsying patients with something else? So I'm always very disappointed in my nephrologists when I get a diabetic patient's biopsy and it just shows diabetic nephropathy. That's a black mark for my nephrologist. What about the association between conditions and the presentation? So this study here divided the presentation into acute and non-acute. So acute being the acute nephrotics or the acute deterioration in renal function. In the non-acute presentations, the most common pathology was FSGS. And this isn't surprising, a secondary FSGS associated with a hypertensive, obese diabetic. Not surprising. The most common non-acute cause of, the most common non-diabetic cause of an acute presentation was various types of glomerulonephritis and tubulointerstitial nephritis. Not surprising, maybe. What I found very interesting from this data was how often diabetic nephropathy causes an acute presentation. So a very high frequency of advanced diabetic nephropathy as the explanation for an acute nephrotic syndrome or an acute deterioration in renal function. And very similar findings were reported in this study as well. If I draw your attention to the bar chart in bottom right, look at the recent onset of nephrotic syndrome. By far the commonest cause of that was isolated diabetic nephropathy. If we look at the table on the left, the commonest conditions found in renal biopsies that don't show any evidence of diabetic nephropathy are various types of glomerular disease, membranous, lupus, and IgA. Superimposed on diabetic nephropathy, the commonest lesions are tubulointerstitial nephritis, and acute tubular injury. Now I'm going to show you some pretty pictures of some of my cases, which get increasingly confusing as we go along. So I frequently see atheroemboli, demonstrated here nicely in my biopsies from diabetics. On the left is a diabetic patient that I got the big biopsy in the post-mortem room after they dropped dead from their aortic aneurysm. And it just goes to show you the severity of aortic atherosclerosis in your patients. And lumps of this are breaking off and embolizing the kidneys all of the time. In terms of tubulointerstitial pathology, this is probably the commonest I see in my Oxford practice. So, typical history, diabetic, acute deterioration in renal function. Any ideas of the diagnosis looking at that? We've got some funny looking tubules, haven't we, with rather flattened epithelium. Well, so long as your pathologist polarizes their biopsies, they will have no problem making the diagnosis, because that's what happens when you polarize the slide. And that demonstrates large numbers of calcium oxalate deposits. And in my experience, oxalate nephropathy is usually enteric in origin, particularly in diabetics. And here we see a case that I reported a couple of weeks ago, which is absolutely classic for the history. I could almost have made the diagnosis based on the history. An elderly lady, long history of type 2 diabetes, but no retinopathy, hypertensive, atrial fibrillation, recent episode of diarrhea, followed by a rapid rise in the creatinine. Biopsy shows acute tubular injury with these dilated flattened tubules and large, very large numbers of calcium oxalates in the tubules. And it seems to be, it doesn't take much in your diabetic patients, usually a bit of diarrhea and dehydration, to tip them over into crystallizing out and depositing calcium oxalate in the tubules, and then they snowball. The lower the GFR, the more calcium oxalate precipitates out. And when they get to this stage, it's usually irreversible. So this is an acute and usually irreversible cause of renal dysfunction in diabetics. Another common tubulointerstitial disease is tubulointerstitial nephritis. Your diabetic patients are on a lot of drugs and they get a lot of infections. But there is a real problem for the pathologist, because there's usually a lot of chronic damage in the biopsies, which is inevitably associated with non-specific chronic inflammation in the kidney. And it doesn't mean to say they have a tubulointerstitial nephritis. This is compounded by the fact that patients with diabetic nephropathy get a lot of eosinophils in their kidneys in areas of fibrosis. This is a recent study demonstrating that. So if you look bottom left of the graph, they've compared diabetes with various glomerular diseases, and the proportion of cases showing an interstitial eosinophilic infiltrate is vastly greater for the diabetics than the other groups. And there was no association between drug therapy and an eosinophilic infiltrate. So the conclusion from the authors is that the interstitial eosinophils, which people think are a marker of tubulointerstitial nephritis, are not reliable in diabetes and are just a manifestation of the chronic tubulointerstitial injury. Then there's the issue of infections, never to be forgotten. So here we see a core from a renal biopsy of a diabetic with rapid deterioration in renal function. Widespread inflammation looks just like a tubulointerstitial nephritis, but luckily the nephrologist sent me 2 cores, and that's what the other core looked like, completely normal. Tubulointerstitial nephritis doesn't do this. It pretty much affects the whole of the kidney. What does this is ascending infection, and this is a pyelonephritis, not a tubulointerstitial nephritis. Then infections can damage the kidney indirectly by causing a post-infectious glomerulonephritis. And here we can see the first of dual pathology that I'm going to show you. So this patient has a nodular sclerosing diabetic glomerulopathy, but also an acute exudative glomerulonephritis. And the deposits were not just C3, as we normally see in a post-infectious GN, but had abundant IgA in them. So this is an IgA-dominant post-infectious glomerulonephritis. This patient was diabetic and had an infected ulcer on their foot. And the pathologist can take great delight in these cases as picking up their nephrologists on the basis of the renal biopsy, tell the nephrologist what bacteria is growing in that foot ulcer, because it's virtually always, in this case, Staph aureus and usually MRSA. Okay, another few dual pathologies. This was a 67-year-old type 2 diabetic with nephrotic syndrome and bladder cancer. They have diabetic nephropathy. You can see the nodular sclerosis on EM, but what else do they have? I don't know if you can see from where you're sitting, but they have multiple subepithelial electron-dense deposits. They have a membranous associated with the bladder cancer. So just because they've got the diabetic nephropathy, it doesn't mean to say it's the cause of the nephrotic syndrome. Here's another one. 72-year-old diabetic lady presenting with severe nephrotic syndrome. Light microscopy shows an advanced nodular sclerosis. This is diabetic nephropathy. But if we look carefully at some of the nodules, they're not all silver positive matrix. There are some gaps in the matrix. Just hope that your pathologists routinely do a Congo red stain. I know they don't in the US and other parts of the world, because if they don't, they will miss this. So this is a nodular sclerosing diabetic nephropathy and amyloidosis. And in this patient, they turned out to have an IgG kappa amyloid deposits in their kidneys. And it was that which was the explanation for the nephrotic syndrome. Now we're coming to our final dual pathology. 52-year-old chap with type 2 diabetes, again presented with acute nephrotic syndrome. This patient doesn't have diabetic nephropathy. The glomeruli looked entirely normal by light microscopy. However, the immunohistochemistry showed beautiful paramesangial deposits of IgA and C3, together with deposits, electron-dense deposits seen on EM. So by definition, they have an IgA nephropathy. So has the IgA nephropathy, with no evidence of inflammatory activity, caused the nephrotic syndrome? No. because the EM showed diffuse effacement of podocyte foot processes and microvillus transformation. So this is minimal change nephropathy in a diabetic patient who happened to have incidental IgA nephropathy. It does get confusing, doesn't it? The really confusing cases are those patients who do have a diabetic nephropathy on biopsy and are acutely nephrotic from having minimal proteinuria a few weeks ago. Can we say that those patients have minimal change nephropathy as well as diabetic nephropathy? Because the glomeruli are abnormal, they've got diabetic glomerulopathy, so the pathologist can't say, yes, they've got minimal change nephropathy. I'm afraid in these patients, it's up to you guys. You've got to decide whether that clinical presentation is more in keeping with dual pathology and the nephrotic syndrome is secondary to minimal change and not just to the diabetes. So we all voted for number 3 at the beginning, and I completely agree with you. Beware, as I've illustrated, renal lesions in diabetic patients are commonly multiple and often confusing. Thank you very much.